The other thing that people are interested in is response to chemotherapy. Chemotherapy provides survival advantage if you give it before you take out the bladder, but only about 20% of patients who have muscle-invasive disease in the U.S. are getting neoadjuvant chemotherapy, even though there's proven survival advantage. And so one of the reasons people don't want to give it is that it has toxicity, and the survival advantage is relatively small, about 5 to 10%. And the thought is that if you can select the patients who are likely to respond, then people would use more of it. And then also, if you're not likely to respond, you can try a different therapy, go on a clinical trial, or go straight to local therapy like cystectomy. And so there have been a variety of biomarkers that have been evaluated. One major area of research has been in DNA repair genes, because the main drug that we use, cisplatin, damages DNA. And if a cancer can repair its own DNA, then it might be resistant to the chemotherapy. And so there have been several studies, one by Dr. Plimak, that looked at a panel of DNA repair gene, ATM, FANCI, and PRB, and found that those patients with those mutations had a better response to chemotherapy than the ones who did not. And they validated that in a separate cohort. And these represent about 38% of patients with bladder cancer in the TCGA. So it's not an uncommon mutation to have. There's been another study looking at ERCC2, which is another gene involved with DNA repair, and also found that there was a benefit in those patients with this mutation who are more likely to respond, and that was validated in a separate study. And there are other genes that people looked at. There's MDR1, which is a protein that's involved with transport or pumping substances out of cells. If a cancer can pump things out of its cell, if chemotherapy got in, it could pump it out. That can provide a resistance to chemotherapy. And people have also looked at BRCA1, which is also involved in apoptosis and DNA repair. There's currently a large cooperative group trial, Southwest Oncology Group 1314, that's actually looking at a Coxin principle. The Coxin principle is basically looking at gene expression profiling of cells and comparing it to a panel of cell lines in the NCI and using that gene expression profiling to predict who might respond. In this trial, they're testing that theory in patients getting neoadjuvant chemotherapy, and they're also going to try to validate some of these other biomarkers. And once that trial is published, it's quite possible that we'll have a much better idea which patients should get chemotherapy based on the response rate. So the talk really concluded in the fact that even though we're not quite ready to incorporate these biomarkers, that there's several different areas that are going to be important. And I think it's important to know who has non-organ confined disease and who's going to respond to therapy, because it's going to be important for clinicians to try to target the patients who are most likely to benefit and possibly spare toxic therapies to those patients who are unlikely to benefit.